button? Okay. So just to give it a bit of background, we know that global health workforce faces challenges. And of recent, we've had the pandemics, evolving healthcare, climate change, which is upon us now, a rapidly changing world, and of course, the global health workforce shortages, which we all know about. And the health workforce distribution remains uneven. Migration, especially south to north, is continuing unabated, leaving the south further disadvantaged. And talking about the MDG era, words have not really translated into action because most of the figures have not changed. Africa still bears 24% of the global disease burden and only has 3% of the world's health workforce, and only 1%, less than 1% of the world's financial resources for health. And that was before we went to the Sustainable Development Goals. But still, the situation has not changed that much. And we have that report of 2006, the World Health Report, and still the picture is still the same. And there's that important imperative for action, which says the unmistakable imperative is to strengthen the workforce so that health systems can tackle crippling diseases and achieve national and global health goals. A strong human infrastructure is fundamental to closing today's gaps between health promises and health reality and anticipating the health challenges of the 21st century. And recently, we had our challenge with the COVID-19, and this really showed the gaps, not only in the south, but in the north as well. So that's why we put this panel together. We need to address these challenges. And for us to do that, we need to train a diverse and adaptable pool of health workers to meet the demands for the future. Because health professions education is the gateway to the health workforce. So we need to train people that will be able to work and function and adapt to whatever situation comes their way. And how do we do this? So this is our point of discussion. I won't go through all the objectives of this session. You must have read them because you chose to be with us this afternoon. So thank you so much for coming. So the question is, how do we do this? And that's what we want to discuss this afternoon. And we have our distinguished panelists to start off with. I will introduce them, then later on they will give us their comments, and then we'll have a discussion and summarize it with still the panel giving us their comments. So we have Judy Kanyola, who is the chair of the University of Global Health Equity Center for Nursing and Midwifery, based in Kigali, Ghana, but also is the secretary for AfriHealth. We also have Stefan Wisbor, who is the managing director at Lecturio, who has worked a lot in the African region with the digital education. And then we also have Dr. Keith Martin, who is very well known to you, and he's a physician and also the CEO of CUGH. Last but not least, we have Georgina Yeboah, the executive director of AfriHealth. Thank you so much for agreeing to be on this panel. So moving forward, we'll go to Judy. Judy will give us her remarks, and then we'll continue with the discussion. Just this.
Good afternoon, everybody. My name is Judy Hanyola. I'm the chair for the Center for Nursing and Midwifery at the University of Global Health Equity. And today I'm going to talk about interprofessional collaboration, education, and I think this is critical when we are looking at developing a global health workforce. And I think everybody in this room, there is nobody who doesn't agree with this. But for some reason, it's not been done so well. Particularly in Africa, we have not been able to really work and bring together an interprofessional education for our health professionals, which ultimately leads to collaborative practice. In my view, I think some of the reasons for this is that there's a lack of understanding what interprofessional education is. And then because of this lack of understanding, other things come into play, like there's a lack of leadership on how to move the agenda forward. And then with this lack of leadership, responsibility, and authority, it then leads to a lack of prioritization, a lack of investment, time, money, people, training, equipment, and all the things that are needed to truly have an interprofessional workforce. There needs to be a new thinking, in the saying that the problems that exist in the world today cannot be solved by the level of thinking that created them. So many of us are products of an old way of thinking. We went to medical school, nursing school, through an old, maybe archaic, outdated model. And like Elsie has said, the challenges that we're facing in this 21st century definitely need a new way of thinking. So health professions need to address the health needs of the 21st century. We need transformative learning, we need interdependence in providing health care, and then this results all of which in health equity. And why, as you know, CUGH was formed, and for me, why I wake up and do the work that I do every day is because we really want to see this equity, particularly in Africa, where many people are disenfranchised, don't have access, face a lot of pain and suffering because of this lack of equity. And equity in health professions education really should be around patient-centeredness and should be population-based, as we've just seen through the COVID-19 pandemic that we've all gone through and we've all come out of, maybe older, wiser, I hope, that need to look at population health is very important. So what is this interprofessional education? I've just taken the CUGH 2002. There are several definitions, very long ones. The WHO has one, and there are a number of people who have this. But this is just basically, in short, two or more professionals learning with, from, and about each other. And I like prefacing this by saying what interprofessional education is not. It is not students from two different health professions sitting in the same class, which is what many people think it is. When I went to nursing school, often we were taught by doctors. So I did like a lot of cardiac nursing. The cardiologist taught us. When we did mental health, the psychiatrist taught us. And people just think that, okay, a faculty member from a different profession coming in to teach is interprofessional. So at CUGH, I teach the medical students. That is not interprofessional education, okay? It is about sitting together, learning with, from, and about each other. Interprofessional education is not participating in patient care setting led by an individual from another profession without then going back to reflect about the decision-making and about the responsibility for health care. So how do we prepare future health professionals in Africa? And again, a lot of this is what all of you know, that healthcare professionals need to be able to collaborate in order to provide optimal care. The patient and his or her need is what is more important than the professionals themselves. And often we've made the process all about the health professionals and not the patient who has come to us at their point of need. And next to our profession-specific competencies, because people think now when we say interprofessional education, does it stop me from being a doctor or a nurse or a pharmacist? No. We are saying in addition to your profession-specific competence, you need to learn an interprofessional competence, and they're in there. They are collaborative competencies, they are common competencies, and they are complementary competencies. So what is AfriHealth doing in this field very quickly? We have an IPE technical working group that I lead, and we're really looking at advocacy and technical expertise, because as AfriHealth, we sit sort of as an overarching network of networks, so to speak. So we are more in the space of advocating for this and providing expertise in this. We have a technical focus document. We have members from about, so far, 18 countries, mainly from Anglophone Africa. We meet once a month on the last Wednesday of every month, and we've developed an IP advocacy strategy toolkit. We also have a great program that we started in 2021, which is called STRIPE, that is Strengthening Interprofessional Education for HIV, that was been done in collaboration with UCSF. And it started in 2021 with PEPFAR funds. And really great for us to be here in LA to meet some of our UCSF colleagues who've been so instrumental in kicking this off the ground. We have 23 modules at the moment on various aspects: PMTCT, advancing HIV disease, COVID-19, TB, HIV, women with HIV, end-of-life issues, PEP, and so on, all the issues around HIV. And these modules are taught online. So far, we've done them online, some places in person, and really bringing the different professions together. It's a case-based model. So we actually just have a case, a clinical case of a patient with HIV, but then we manage it together as different professions. It's focused on subject matter competencies, but in addition, collaborative competencies. What does it need for us to work together within our different professions? We've published results in peer-reviewed journals, and slowly but surely are improving the IPE competencies of health professions in East Africa. AfriHealth also has small grants that started in 2022 through NIH funding, and we are now in the second iteration, about $20,000, not a lot of money, but it's something, and it's making a difference. And one of the requirements to get this AfriHealth grant is to be interprofessional. So we have schools of medicine working, schools of nursing, for example, and even cross-country. So Uganda, for example, working with colleagues from Ethiopia, or in Zambia and South Africa, and so on. And again, slowly but surely, improving competencies of health professionals in Africa. I'd just like to end my slides today by looking at this, instead of focusing on stumbling blocks to stepping stones, and avoiding the epi-professional, where in the past it was looked at the clinical professions were above. So sort of often doctors are above nurses, and then nurses are above those who are not clinical, moving away from substandard, sub-professional, to really embracing extra-professional, where we are talking to people even outside the health professions, because a lot of the challenges we face these days just can't be fixed by the health and the medical information we have. One of the things that really, I don't know, I hate when I go to hospitals in Africa. I've worked in hospitals for over 30 years. My work as a nurse, it's just the way our hospitals are designed. Why do we design our hospitals in such a non-patient-centered way? You know, sometimes even when I go to Butaro, where I work, we walk up the hill, then you walk down the hill, and then you're in the lab is here, and I don't know, the pharmacy is here, and I don't know who designs these hospitals. And I'm like, please, there must be a better way of doing this, you know? So let's go beyond our professions and being maybe hyper-professional. Let's really take the physicians to task. I mean, I'm doing my studies right now, and one of the things I read is that there's a report in the US which was published, I can't remember the year very well, but it was called To Err. And because of that report, where they were talking about medical errors and the cost of medical errors, I know in Africa I have seen literally my own colleagues, I want to be honest, kill patients because of a medical error. You give too much insulin, the patient dies. You cut a little bit to the left and the patient dies, or not to the left, you know? So can we be hyper-professional and push ourselves to the maximum of our limits to be professional? We keep patients waiting for 3 hours, 4 hours. I wonder really if that's the standard. And we've sort of just agreed that that's what it is, and patients come and they sit and they wait, and we really don't care. Let's push ourselves to be hyper-professional, you know, interprofessional, like I've said, and even meta-professional. Let's go over and above. What is it that we really want to see, like in an utopic world? Supra-professional, and last but not least, ultra-professional. I think if we can embrace all this, then for sure we are going to build a resilient global health workforce. Thank you very much for listening to me.
Thank you very much, Judy. That is very inspiring. Meta-professional. Yes, that's the way to go. Yeah. So next we'll have Stefan talk about the scaling up digital education and his experiences with this.
Thank you so much. And don't need to do anything on the screen here, or? I have the clicker, yeah. So, perfect, great. And I thought panel is just talking, you know, then I remembered how long these sessions are, so they just put up the slides for me from the last World Health Summit, so thank you for that. Don't tell any of the organizers. So, pleasure to see you, Stefan Wisbauer. I'm based in Germany, and I'm going to talk a little bit about what we do, and it's really an encouragement for collaboration in many different ways, and I'll be more specific about that as I go through. I'll try and be swift so we have time for discussion afterwards, which is always, I think, good to be engaging with you all. So in terms of what we build here is basically a precision health science teaching engine, and it's a real leapfrog opportunity. And I'm particularly excited about the African context because I think the willingness to leapfrog there, my home turf is Germany, you know, and so we kind of know what we're doing and we think we're good at what we're doing, so we don't see a need to change things fast, right? But obviously the technology is available these days, AI, but also things that have been around for a long time, you know, learning science evidence around, you know, retention and spaced repetition learning algorithms and their effectiveness. But do you know a university that is tracking and incentivizing the learning process and the assessment in a manner that maximizes long-term retention? I don't know, happy to see a show of hands, you know. It's usually summative assessments, and then there's the next summative assessment point. Doesn't matter if you've forgotten 80% of the previous one, right? So if we're honest about ourselves, then the rate of adoption of science and teaching science and learning science into our teaching processes is often woefully slow. And if we look at, you know, I think in the African context, I always love the energy also. You can tell from the speakers, you know, they're always energetic, ambitious, optimistic in many ways, facing also a higher need and urgency in many areas, and you know, more complex benchmark that makes it easier to innovate. Because if the alternative is to have no service at all in that rural area, maybe the adoption of smart, remote, AI-supported, you know, people doing other things than in the traditional systems that we've built in the high-income countries. You know, I think there is more openness and also a huge set of opportunities. And so ultimately we should leapfrog to that. You know, so here's you have an image of the traditional CT machine. And you know what we're trying to do is have the CT scanner, basically a lot more data. So in our system, for example, we have 12,000 plus videos, 30,000 plus tracking questions. So the learner gets a formative assessment point on average for every 3 minutes of their learning. You know, so for any faculty, that means a lot of data to work with and optimize and adjust the teaching to. And so it, you know, therefore becomes an engine to support all of these. Actually, I can look here. Support all these modern ways of teaching that we need to bring about. And the technology support for that is one thing. And also this is a unique leapfrog opportunity in that regard. But obviously it takes leadership and change management capability and the ambition and the openness to actually try these things and iterate them and measure them and so on. So in terms of the content base, we have a very comprehensive content base. It's mainly educators from the US, including many of the top schools, like you can see here. But we also co-produce a lot with local faculty, and I'll show some examples of that in a second. The whole design is really to support both the learner and the faculty, so learners often, you force them into lecture halls, and, getting their attention might not be easy. Where you don't force them into lecture halls, they often opt to jump around the internet and watch YouTube videos and things like that. So here you're trying to bring the learner back together with the faculty, and actually there's good learning science evidence. People like watching videos, but the learning science shows that videos are a pretty effective way of, learning a concept initially. So in terms of the content base, these are some samples for what this looks like. Videos are very short, for example. That's another learning science principle. I mentioned the formative assessment part already. And then there's both, theoretical, but also a lot of practical support. Obviously, it doesn't replace a nurse learning how to, do these tasks and get an IV inserted, etc. But the optimal digital support for that process is still valuable. Then you need to apply these things to clinical cases, and this is an interesting example here where we've added an AI tutor to that case case-based learning. And if you look at the evidence historically around tutored and individually tutored learning and mass instruction, so to say, much better outcomes, much higher range, much narrower range, and much better learning outcomes. So how can we use the modern technologies to get closer to that kind of reality, because even in a good US school, well-funded, etc., one-on-one tutoring for every student is obviously not realistic, but with AI you can start to approximate these things and get some of those benefits, hopefully. And we're very interested in evaluating those kinds of things together with all of you. Many of you are researchers, so we're both interested in helping be an engine for research that is very data-rich, but also think beyond the research, like what are exciting innovations that we could push, and we just track and adjust as we go along. Not everything has to be a randomized controlled trials. There's a lot of unmet needs out there, and often you can find a rather direct route to meet those needs and get that feedback and that measurement pretty quickly. So in terms of the continuous side, we now have continuous education credits also this is from the US, but just getting those adopted in Ethiopia as well, hopefully. The ministry will respond to that soon. And in terms of using it in any of your healthcare systems, whether it's Africa, we also work in Afghanistan and Asia and so on. So really any country you're from, we're happy to talk to you. And you can use it both for the education process, but also the in-service learning, which obviously is more and more important because medicine changes more and more rapidly. Here's an example from Ethiopia. So here we produce training for equipment use and maintenance with the local Ethiopian experts. So on a number of devices and machines, many of which Chinese, got to teach them how to use the stuff that they have, right? The latest edition, we've kind of created an AI question generator for faculty, because that's obviously a lot of time often spent creating new assessment questions. You can meaningfully accelerate that and optimize the prompting there, store it straight into your question bank, and save a lot of faculty time. And if you're short of faculty, like that's definitely the case in Ethiopia, but in many other countries, even in Germany and elsewhere, then this is a helpful time saver, so you can then redirect and invest that time looking after your students and so on. So a lot of analytics in the system. As a result, I mentioned the data generation. I'll be fast on these, so we have time for discussion. At the bottom here, I just want to point out this little R sign. Many of you are probably familiar with R, the stats engine. So any dedicated white label accounts that drive these interventions, which are locally controlled, that's important. You can get direct access to the R folder. So therefore, you're able to really work with a whole data hose and run your analytics on that with whatever tools you're using. Here's a sample for what it looks like integrated into an existing system. A lot of the institutions have systems in place, whether it's a Moodle or a Canvas or any other variant. This works through LTI. But the good thing is if you don't have a system yet, then we actually become the substitute for that system if you like. Use cases, I don't want to take too much time to go into those, but just to mention, you can support both the traditional learning process as a substitute, but you can also easily drive blended learning, flipped classroom learning, support simulation learning with briefing and debriefing, etc. So there's really little limits to the various areas where you can do this. If we did an evaluation with faculty, some saving potential per week of 6 to 12 hours per week, on prepping for teaching, on teaching delivery, on assessment, on remediation, all the things they're supposed to be doing as faculty in a nursing or medical school. So spaced repetition I mentioned earlier, so I won't spend too much time on that. Just to mention the forgetting curve is a scary one, right? So in a week you're going to remember maybe 10% what I said, and so this is a substantial aspect. And if you can optimize this is what it looks like on the platform. Then you can save the students a lot of time relearning and revising at the right and effective moments and track that. And if you want as faculty, incentivize that, so. And this has been around for a long time, but it's not really been implemented very much. This is the tutor already mentioned, so you see the clinical case question, and then the tutor will coach you and give you hints responding to your sequence of answers, and we're evolving this further to kind of go into broader dialogue, etc. Here are some of the areas where we're active, but the need is everywhere, so wherever you're from, we're happy to talk to you. And the idea is really to work across the system. So final thing I'll mention is just our efforts in Ethiopia. So there we're working with about 10,000 learners in the medical schools. Each medical school has its own platform that they control. The curriculum is mapped into the platform. We then train the teachers and the faculty in how to work with that effectively. Then we're working with nurses and technicians on training for equipment use and maintenance. That's funded by GIZ, both of those. And then finally working with the community health workers with global health funding. And this is another area where I want to encourage you to come talk to me if you like, if that's an area of interest of you, because there's a lot of interventions there that don't generate data. And it's really important that if you're doing those interventions, not only you have the right content, and we have content and we can co-produce more content, but also have it generate data so you can do proper scientific evaluations. That's it from my end, so looking forward to the discussion. Thank you.
Thank you, Stefan. I think we all have to go digital. I think COVID woke up a lot of people that had resisted digital education, and there was no way they could do it any other way, so everybody had to get on board. So thank you for that presentation. Next, we have Dr. Keith Martin to talk about collaboration in global health education.
Thank you very much, Elsie. It's a real honor to be here today. And I want to, for those of you who don't know, Dr. Kajuli Malawati is the winner of our co-winner of our Distinguished Leadership Award. Which means you have to be there tomorrow when she receives it, because she's going to give a lovely speech at that time. So we're really honored that you and such a great the AfroHealth leadership is here with Georgina Yaboa and Judy and others, and so we're honored that you came over a long way. But the fact that the leadership in AfroHealth here really speaks to a relationship we've had with CUGH, with AfroHealth, and centered around one of the big things we're doing is in training. And I also have in the audience Dr. Nancy Reynolds. Nancy. Professor Reynolds is the Vice Dean at Johns Hopkins in nursing. She also leads our capacity building workforce subcommittee. And the reason why I'm saying that is that what happened in the area of training for us at CUGH is we co-created with Elsie and Nancy and Andrew Dykins and others an exciting capacity building site. So if you have a chance to look at it, it's CUGHcapacitybuilding.org. So www.CUGHcapacitybuilding.org. And we created that site to deal with the challenge that we're trying to deal with today is how do countries that have a huge human resources deficit in healthcare or other areas, how can those be met? So this site is really, it's like eHarmony without the romance, okay? So on one hand, institutions that have training needs are able to post those, and on the other hand, those that have training capacity can also post their capacity, but also they can meet each other, which is what we wanted to do. So with Elsie and Nancy and Andrew and others, we co-created this platform. And our aspiration is for for anybody can use it. Please use it. and use it to be able to address some of the human resources challenges you have. So what I wanted to do today is really look at a few aspects. One is share with you, which I've just done, that relationship we have with AfriHealth on the training side, retaining, which is equally important, the skills you need, and also a couple of other points that we don't talk about, and that's critical infrastructure needed to take advantage of great products like Lecturio that people can use. So this issue, for us, obviously we know what it is, but to breathe life into it, into the real terms, we work with Sierra Leone, with the government of Sierra Leone. Now, that country went through a horrible conflict. 250,000 people died. Over 11,000 people died in the Ebola outbreak. So it's got significant number of patients who have been deeply traumatized with huge mental health care needs. Now, if you ask the question, how many people and how many psychiatrists are there in Sierra Leone? Does anybody know? 2. If you ask the question how many nurses there were with specific mental health care training capacity, the answer was none. That's staggering. But there's an incredible leader there, physician, who's working with us and our partners at Harvard and public PHI to be able to go and help to train their capacity to train their own folks. They have a new hospital to do it that Judy would love to see, but they need trainers to help them. So what we hope to be able to do at CUGH is being able to take the incredible assets we have on both sides of that equation and bring them together. The second thing is in the area of professional associations. And some professional associations, I hate to admit it, actually do not make it easy for individuals who are being trained to actually practice. Those that are involved and leading some of those associations, health associations, make it very difficult and act as an obstacle sometimes to individuals who are trained to be able to practice. So one of the things we have to do, I think, is to engage our associations, engage their leadership, and make sure that our professional associations are not an obstacle to training and retaining people in the country, which gets me to retention. We can train all the people in the world, right? But unless those people are hired and have the resources to be able to support them, they're not going to be kept and they're not going to be retained. So it gets back to, again, that political question. We've got to engage governments for them to show them, go to them, and show that an investment in their healthcare resources and their systems is a positive investment in the economics and the security of their country. But they're not going to come to us. We need to go to them. The next part of the retention, of course, is I'm pointing to all of us in high-income countries. It is absolutely immoral that we march into low-resource countries and steal their healthcare workers and invite them to come back to their countries. That is something that happens, we know, but it is completely immoral that happens. That's utter thievery. Anybody can leave if they want to any countries. That's the individual's right. But a country, a high-income country, cannot have a strategic effort to go in and take the trained healthcare workers from a low-resource setting and bring them back into their own country. What they can do, and this is what we did in Canada as a proposal, was if a country accepts somebody from a low-income country, then the recipient country should train 2 individuals of an equivalent skill set in that country. Not 1, but 2. So I think that, at least as I said, if individuals have a right to go where they want, but if a country accepts them, they should train 2 people on the other side of that. Finally, on the issue of infrastructure, all of us have been on umpteen calls where our friends and colleagues in low-resource settings where the internet connection is broken up. The digital divide, as all of us know, is a very real obstacle to achieving training and access to healthcare products. We tried really hard to get IT gurus and big internet companies and those that have more money than God to come to this conference, to actually present at sessions like this, right? So we can cross-pollinate. We tried really, really hard for a long time, couldn't get it. But I think that they need to be embarrassed to actually say and provide an opportunity that fully 3G access is critically important for countries and professionals and trainees to access the kind of products that exist out there and the opportunities for collaboration, clinical care, and training. So addressing that digital divide is, from our perspective, I think, personally, a really important advocacy issue that receives short shrift. Because technology and important products like this without access they're not accessible, and that's a huge waste. Finally, on the skills area, we all know that healthcare is an ecosystem. So not only do we as clinicians need to be able to have the stuff to do our job, but think of it this way. If you're the best surgeon in the world and you don't have access to electricity or healthcare products, medicines, the trained nurse beside you, the anesthesiologist in front of you, the power that lights up the lights and your products, if you don't have that, then you really are not be able to practice as the best surgeon in the world, right? You're not be able to do much. So it's our plea for all of us, I think, to do our best to be able to work with governments to strengthen out the infrastructure needed to support our work. We need good managers in hospital, right? We need people who can manage the budgets, manage the supply chains, manage the human resources, and that requires training. So as we're looking at strengthening health systems broadly, I think it's really important that we also engage, as was mentioned by Judy and Elsie, we've got to be able to bring in other skill sets and other disciplines, because those disciplines are the foundation of the ecosystem that enables all of us to deliver the care that our patients need. And in that regard, some skills that are necessary are project management, monitoring and evaluation, biostats, leadership and communication. Finally, for those of you who are in high-income countries here, there's a strong desire to have experiential learning. Let me just share something that can be applied, frankly, anywhere. I was giving a talk at the American Association of Veterinary Medical Colleges. Now, Dr. Andy McCabe, who's the president of the AAVMC, is here at our conference, which we're honored at. So I gave the talk, and I was walking through the poster session. I'm walking along, and I went, dentistry? What's dentistry doing at a veterinary, a veterinary sciences meeting, the top meeting? So I stopped and I asked the woman there, I said, tell me about your poster. So she was a fourth-year dental student. And what this university did, and it was in Texas, this university went to, the dental school went into low-income communities and said to those low-income communities, do you want our final year students to provide you with primary dental care that they could never afford in a million years? And they said, sure. And then they brought in the veterinary students and said, by the way, you have pets. Do you want us to go and enable our fourth-year veterinary students to give your pets the type of primary dental veterinary care that they need? They said, absolutely. Imagine this, a low-income community that would never have access to dental care, and vet care for their pets are important for health reasons, they would never have that. But think of the permutations and combinations. Why can't a nurse be with a physician, or a nurse trainee be with a social worker, or a physician be with a final year law student to help people navigate their social systems? Imagine the research opportunities embedded within that. It's a win-win-win situation, right? Communities get access to services and care. Doesn't cost very much money. Students get incredible real-life training. It's safe and it's supervised. So I just a small little vignette just to share with you in your own programs, wherever you happen to be in the world. If you care to operationalize that, but use more than one discipline, you'll create an incredible interdisciplinary moment for training. So thank you so much for your time.
Thank you very much, Keith. That is really beautiful. I've seen it work in some parts of Uganda. Makerere University is doing it, and it's incredible how much you can achieve through that kind of arrangement. Thank you for bringing it to our attention. And thank you for giving us the platform as AfriHealth to come and talk about what we do. Last, we have Georgina Yeboah, the Executive Director of AfriHealth, and she's going to tell us about the innovations and adaptations of new models of education that AfriHealth has adopted. Thank you.
Thank you, Elsie, and thanks to those who have gone ahead of me. All right. This is just for the information of those who don't know about AfriHealth. Because we came and we are asking people whether they know of AfriHealth. And so whenever we get the opportunity, we want to share something briefly about AfriHealth. We are a young organization. We are 4 years behind CUGH, or how many years behind CUGH compared to CUGH? We are some years behind them, and so we are a young organization, but they are our partners anyway. And we came out of the MEPI programs, so they were our parents, and they brought forth to AfriHealth. And AfriHealth was established to ensure that health workers come together, work together, address the issues, health issues on the continent. And that is what we are doing, and that was what Judy presented. And also, we are also established to promote South-to-South collaboration. There's a lot that Africa has, and we need to come together to be able to share what we have in terms of all forms of resources, especially human resources. Some of the activities that AfriHealth is involved in are research, capacity building, knowledge generation, sharing and learning, advocacy, and our student interprofessional exchange. One of the goals of AfriHealth is to address Africa's human resources for health challenges by promoting contextually relevant and transformative interprofessional health education in African institutions in order to contribute to increasing the numbers and quality of healthcare professionals. So the numbers and the quality of healthcare professionals is very important to AfriHealth. And some of the programs that AfriHealth has engaged in include the student IPE exchange. So I'm talking about programs in relation to health workforce training. Learning management system, strengthening interprofessional education to improve HIV care across Africa, that is the STRIPE HIV program, faculty development, and a new one that is loading, it's the nursing leadership development. With our student IPE program, we are able to bring students together from one Africa institution with another Africa institution, and they learn best practices. With COVID, because of restrictions on mobility, we decided to do it virtually. And it is interesting how we're able to do that and still been able to train 180 students from 13 institutions and 9 African countries. That is the power of South-to-South collaboration. So students are able to learn from other cultures, but looking at similar conditions or similar situations in those contexts, which they can come back to their countries and apply. And it's not just one profession. So for instance, some of the institutions, they have about 5 students from nursing, from medicine, from dentistry, from pharmacy, from lab, or from physiotherapy, who are put together and they are attached to another institution on the continent. They have faculties and they have a project that they work on together. And I must say that there was a student, if you go to the AfriHealth website, you can read about this and then some of the comments. One of them said, we didn't know about this. It is so beautiful when we are put together. So this is an initiative of AfriHealth, an innovation, a model of education that we've brought on board. And we are going to continue to work on that. With COVID, running programs in person became a challenge. So we needed to look at how we could really get people to learn despite the restrictions. Together with our funders, NIH, Fogati, UCSF, with funding from HESA, we were able to develop our learning management system. And we have 22 models on HIV and COVID on that learning management system. We also have a course with Stanford University on COVID course for healthcare workers in LMICs. And we are also putting on additional courses on scientific writing, and the student IPE models are also going to be put there. Our leadership development models also, we've put them there. And since 2021 that we have our learning management system, our total enrollments have been 10,300 from 30 countries, from Africa and outside Africa. It's surprising that looking at the details of the countries, I saw enrollment from the USA, from Pakistan, from Switzerland, and other countries outside of Africa who are benefiting from this all-important platform that AfriHealth has. Judy talked about the Stripe HIV, so I would want to emphasize on what we've been able to achieve together with UCSF. From 2019 to date, with that opportunity given to people to work interprofessionally, we've been able to train 16,000 health professionals. We've partnered with 182 institutions and governments and facilitators that have also been reached, 1,586. Because they are facilitated, they facilitate the training, and they are trained, they are capacitated for them to be able to conduct the training. And one of the things that we do is that we invest in institutions for them to also modify the courses that we have to suit their own settings, and they run it. And for this course, we do it for pre-service health professionals, then the health professionals who have just completed school and are working, and then we also have in-service also coming in. And we do it interprofessionally because it is not just one group that can do it. So it is both online and facilitated. That is how it is done. So we ensure that we don't lose the interprofessional aspect of that. We don't leave faculties out because they are the people training our products. So we also have the James Hakim Leadership Development Program that we've been running to ensure that we build middle level faculties, their capacities for them to also take up leadership positions as provosts, as deans, as heads of departments. And from 2021 and 2022, we're able to train 61 fellows. So these are the people who graduated from the training program. Now, there are a lot of online training programs going on, even in institutions. How can faculties be able to facilitate such programs? So one of the programs that we did together with Stellenbosch University is to train facilitators for them to be able to facilitate online programs. And we've been able to train 90 people out of that, and we've used them to also train others and run the programs that we're doing. AfriHealth, talking to our members, noted that we have a lot of young professionals, especially in faculty. And people have challenges teaching as expected in certain areas. So we put together a team, which Judy, sitting here, yes, was part of. Very passionate about it, and we've developed a pedagogy course that we are going to run this month. So we've started our enrollment with that. The last one that is loading is the nursing leadership program. Today, in one of the sessions, people were raising that issue about nursing leadership. And AfriHealth, together with UCSF, has worked on that. And this month, we are going to also start nursing leadership. And this one is for in-service. So AfriHealth is not only looking at health professions education, but also in-service, because we are also there for service delivery, excellence in service delivery. So how do we train our nurses so that they can also take up leadership positions at executive levels and then also at the policy level, so that we can see improvement in healthcare? We have a lot of nurses in our healthcare system. They are the majority. And it's important that we also equip them to be able to do that. All right, so thank you very much. This is what AfriHealth is doing. And we want to also invite you to our symposium in August in Nairobi. So you can take a picture of it. We will also share the flyers with you so that you can hear more about the work that we are doing. Thank you very much.
Thank you very much, Georgina, for that overview of what AfriHealth is doing. We are trying as much to be innovative and to make sure that we meet all the constituencies in our organization, because we are an interprofessional group and everybody has some interests that they have needs that we need to cater for. So we have quite a number of programs and everybody finds something that they can do in that organization. So thank you, Judy. So we can now have, if you have questions or if you have comments, points of discussion, this is the time for us to interact. Please go behind the microphone and then we'll go ahead and hear from you. Right at the back, I don't see you very well, but
that's
please.
Okay.
Yes.
Thank you very much for this amazing focus on workforce. My name is Dele Ogunshaitan, and I'm at UC Irvine, but for CUGH, I chair the competency committee, and we are just about to publish the third edition of that competency toolkit that we hope will be adopted as guidance for developing programs across the world. I'm very happy to say that one of the members of the subcommittee, Priska, is also with AfriHealth. So we know that we have a direct line to your feedback on the toolkit. My question is about how programs that are developed internationally trickle to universities. In the last year and a half, the World Health Organization's Health Office has been working on a roadmap for training in emergency response and public health engagement. And because it's WHO, they have to go through government channels to make sure that countries recognize and accept the roadmap. But I think they need to also work with organizations like AfriHealth. But probably what would happen is that the ministries of health will be the recipient of the roadmap and then find institutes within their country to provide that feedback. So I just want to know how AfriHealth is connected to this political system that is responsible for accepting and providing information for what we all know is important to have international collaboration around workforce training and retention. All the points that you raised, we need to have not just bilateral agreements, but agreements across all countries about best practices. Thank you very much.
Okay, thank you. We'll take those three and then we'll discuss. The lady in the front.
Thank you very much. My name is Nada Fadol. I'm from University of Nebraska, Professor of Infectious Diseases. And I'm a big fan of AfriHealth. I wanted to say that in public. So thank you, Elsie, Georgina, Judy. I reached out to Judy a few months back asking for assistance with nursing leadership development in Sudan. That was before the war, actually, more than a year ago. And she was extremely helpful, very generous with her time and resources. And I just wanted to point that out, that you guys stand for the mission that you acclaim. The question that I have right now, with a continent that's constantly going from one emergency to another, one disaster to another, one war to another, what AfriHealth is doing to help institutions, academic institutions, navigate through these difficulties. Medical schools and nursing schools, all schools in Sudan right now are closed because of the war. That happened in Ethiopia, happens in other countries. And these students stay for years without education. So how can an organization such as AfriHealth help these institutions navigate through that? Thank you.
Okay, thank you. The last one at the back.
Hi, my name is Anmol Shrestha. I'm a second-year medical student at the California University of Science and Medicine. Thank you guys, first of all, for a really amazing panel, especially Dr. Keith Martin. You talked about the steps that Canada has taken to prevent brain drain. I've in a lot of conversations with other medical students from Nepal, Pakistan, Ethiopia, and even Kenya, are hearing just a large amount of students who are now preparing for step one and have the intention of applying for residency in the States. I know the UK has had programs where they're trying to bring nurses from LMICs. So I guess my question is, what concrete steps have you guys seen in trying to curtail the number of brain drain that's gone from LMICs to high-income countries, and specifically, are there any strategies that you've seen that have worked?
Okay. Thank you very much. Excuse me. The questions are not just for the panel, so if you have something you'd like to respond to, please feel free. It's an interactive session. As I wait for people to respond from that side, I'll begin with my panelists. And I don't know, anyone who would like to respond to any of those questions? Yes, Stefan?
I will, but I don't want to go first since they were addressed to AfriHealth and we're just members, so.
Okay, Judy, would you like to go ahead?
Thank you, Nadal, for your kind words. Very nice to interact with you from Sudan, and I'm really hoping we can take up further discussions on especially the nursing aspect. And thank you so much for your dedication to AfriHealth. It's noted, and I'm grateful. I think for me, around the emergency areas, especially in countries which are facing, especially suddenly, you're in school and then you can't be in school for conflict, war, and other unforeseen events. AfriHealth, one of the things we are working hard on doing is actually having the learning management system and having perhaps what now from your question we need to do is see how this can be accessible to people even when they are, not able to go to school, for example. I think Stefan's lecturio will certainly be something we really need to consider in great depth on how to provide that kind of ability to learn online, even despite the challenges of electricity, of internet, and so on. And these are things we talk about all the time. I know even at UGHE, our nurses, for example, in Butaro, don't have access often when they leave the hospital, for example, to internet. So how do we still teach them? And we are teaching them, for example, critical care. One of the things we've done is try to see how to get offline modules. But I do take that as something that's a challenge. The other thing perhaps to say is that mentorship is important, and while maybe you may not be able to go to school at that particular time, it's helpful to have somebody to talk to. And I think AfriHealth provides a myriad of professionals across the health professions, not even just clinical, that you can tap into, experts, people who can even at the time maybe you're not able to go to school, you can continually interface with and talk to and provide that support. Thank you.
Yes, Georgina.
Right. All right, so on the competency-based tool, we'll be very happy to make use of that because we also have a technical working group on competency-based education, and that will be very good because they wouldn't have to reinvent the wheel because there is something that's already existing. So we'll be waiting for that competency-based tool so that we can get our lead for our technical working group to also see how we can utilize that. And on how we can ensure that institutions get access through the ministries of health to WHO programs or training programs, I think that we will have to find out whether institutions have access or not. Because before we can say that we are going to get the institutions to get that, because I know that our various institutions also work with the ministries of health in their countries. So we will need to really check on that. If we don't have access to that, then we know how to do it. And I know that WHO also have the WHO Academy, where such programs are also put. So it's open to everybody, and so I think they will be able to access that. But we will also check with our contacts in WHO if there is a way of they sharing such information with us when it is going out, so that we can share with our community, because we get such information from Africa CDC that we are able to share with our community, and so when we have that. Then on the brain drain, just February, our governing council constituted a team to write a paper that we will present at the WHO Assembly on that. So they are working on the brain drain issue and will be able to come out with a paper on that to address the situation.
Thank you, Keith. Oh, okay, Stefan, then Keith.
Oh, no, Keith, go first, please.
Go ahead.
You can go first.
Okay, good. I'll be brief. So just very briefly on this disruption question. So as I mentioned, we did this large-scale program in Ethiopia funded by GIZ, and it was conceived due to faculty shortages, a lot of junior faculty, the desire to increase the number of graduates and so on, but it happened to hit during COVID, right? So it ended up being a very meaningful support for the system, for the medical students to be able to continue to learn during the COVID disruption and really have very comprehensive content available. That included students in rural areas with sweet stories of them going up the hill to get reception to download the lectures for the day and then learn during the day to repeat the same thing next day and so on, And the dad had to pay the Wi-Fi fees, which are still not cheap by local standards, but the son could continue to study. We work in Sudan with the National University of Sudan, so with the disruption right there, right now, that is again very meaningful for them. We've done a lot of work in Afghanistan. We're hoping to do a virtual medical university in Afghanistan with some partners in Canada. In Ukraine, we supported some of the universities also with the disruption of the war, and we're working on the negotiations at the moment with the DEG in Germany to do EMS, so emergency medical side of things, training support on that front. So that's not final yet, but we're close, so hopefully we'll get there. Similar conversations underway in Myanmar. So if you have any interest in disruptive settings and you want to, support to continue the institutions in those settings, happy to have that conversation. Final thing I mentioned on the brain drain, I liked your kind of suggestion there with the 2-for-1. Obviously, there's some African countries like Kenya where the president and the system, openly encourage people to go abroad, and so it's a differentiated picture, right? But I often share that if you put our system into a nursing or medical school, you should be able to, significantly increase the number of students, at least when it comes to the didactic side of the education, without increasing, facilities or faculty. So the kind of a lineup around that might be interesting to enable this 2-for-1 to happen more easily. I very much like the thought, So. Thank you.
All right, but the number of, if you even increase and they are still going, because I know that in Ghana, we increased the intake into the nursing training institutions. The other issue is about government employing people, because we cannot overlook that. Because we know that in countries where people have completed school 2 years and they don't have jobs. And now these people are going. Initially, it was those with experience who were going. Now, those who have completed and have finished their internship are also going because they don't have jobs over a period. So we need to really look at how we address that brain drain issue. Thank you.
Over to you, Keith. Yes, please.
And Georgina's point, a country is desirable, of course, to have an integrated health strategy for your health human workforce, right? And needs to be planned out. What do you need? Where do you need them? We haven't even touched on the issue of the urban-rural divide, about how you can train and retain people where the need is greatest, which are actually in rural areas. So I think for those of us who are all in the space, engaging in governments to be able to have a health human resources strategy that deals with the future challenges as the demographics are changing, as the disease patterns are changing, as the NCD burden increases, it's important for us to work with governments to push them forward. Whereas governments often have a 2 to 4 year timeline, this is obviously, as been discussed before, this is a 30-year plan, right? So we've got to somehow engage governments in looking at this problem in a 30-year plan. Finally, on the conflict issue at CUGH, what we do is if there are institutions that are training in a conflict environment and they're on tough times, they join CUGH for free. We did this in northern Syria and other areas, and we'll give whatever we need and support for them as they ask us to do. We wish we could do an awful lot more, and maybe later on, if you want, we can get into the issue of what happens to people in IDP camps, internally displaced person camps, or those that are refugees that have been started their training but had to stop because of conflict. There are a number of creative things we can do, but we have to really approach our universities and governments to say this is an essential part of advancing security worldwide. Thanks, Elsie.
Thank you.
Just a very brief addition, if I may, back to what you said earlier, Keith, around the case for health. I think often in medicine, people are trained to make the case. Obviously, the public health professionals hopefully know a bit better on average, but are trained to make the case in terms of health outcomes, right? But unless you studied preventive medicine, which is a specialization in the US and Germany, for example, it doesn't exist, right? There you see very clear calculations around the benefits of reduced risk in the population in terms of economic productivity and GDP impact, and so I think the health side, the ministries of health sometimes need some support in making that case to the Ministry of Finance to get, sufficient means in that important direction. So, sorry, just wanted to add that.
Yeah. Thank you. And there's a gap, especially in the ministries of health in Africa, in health workforce planning. And this is not being addressed. I mean, we increase the number of intake without knowing where they will go. So that is something, that is also an expertise that is required if we are to plan for for our human resources for health. Sorry, you've been standing for a long time. Please go ahead and give your comment or question.
I guess so. Is it on? Okay, great. Yvonne Commodore Mensah, I'm associate professor at Johns Hopkins and also president and co-founder of the Ghanaian Diaspora Nursing Alliance. So I'm so glad the gentleman asked or made a comment about migration. So this is a shameless plug. So tomorrow, we will have a panel on the migration of nurses from low and middle income countries to high income countries at 4:30. And we are going to discuss this very nuanced topic of migration because fundamentally, migration is a human right. People have the right to work anywhere and everywhere. But, and I'm so glad Georgina said, in Ghana, there are about 90,000 unemployed nurses. Sit with that number for a bit. So when we talk about human resources or for health, it's very nuanced. So at the panel, we will also have a representative, Dr. Michael Joseph Dino from the Philippines. So you'll hear the Philippines perspective, as well as the African perspective as well. And actually, one of our panelists, Angela Gori, migrated from Ghana to the UK. And you learn that the grass isn't always greener on the other side. Because when you do arrive, the nurses sometimes are not treated fairly and equally. So we invite you all to attend our session tomorrow at 4:30. Thank you.
Okay, thank you. So 2 minutes for each of you, then we will get back to the panel for final comments. Please be brief. Thank you.
Yeah, thank you very much. My question goes to Stefan. I'm Dr. Patricia, and I'm a senior resident in Makerere University. And I am a big fan of Doctorio. I use it as a student, and it has been really nice to see the wide range of products that you have for faculty and proctoring and everything that it is that you have. I think for me what has been prohibitive is the price of Doctorio. And it can be available at a price, but a price that's friendly to the global south. Are there any efforts to make it more available, even if it is at a price? Thank you.
Okay, thank you. Before you, let's have the last one. Thank you very much, Patricia. The last one.
This is Enid Kawala from Busitema University. So my question is related to the Stripe HIV courses. I'm proud to be one of the facilitators. However, we've been limiting these courses to only healthy workers, but when it comes to our students in the clinical years, you really feel that this content is also beneficial to them. Have you really discussed with some of the leaders of these medical schools like Faculty of Health Sciences, Busitema? We tried to give a few students a chance to go through them, and they are quite different from those that have not gone through these courses. So is there a way of integrating some of these courses into our curriculum? Because these components are there, like the course I've been running, palliative care or end of life, it is there, but it's not as rich as the Stripe HIV course. Do you have any plans to do that? Thank you.
Thank you. I think our plan is to have people like you that are enthusiastic, so that you make sure that you use these courses with the undergraduates. And some people have actually integrated these cases into their teaching, and it is working efficiently. So we are calling upon faculty, people like you who are really have found them of value to use them with the undergraduate students as well. Thank you. So thank you very much, our audience, for the comments and questions. Now I'm going to give a chance for our panelists to give their final comments. They can also respond to those questions that we had just before we came back to the panel. So over to you, Stefan, then we'll go up to Keith, and then we'll end our session.
Thank you. So just on the affordability question, so on the one hand, please come see me. I can get you a code. that goes beyond the normal online research. But frankly, my view is you shouldn't have to pay at all. And we've been in discussions with Makerere University, and we've signed a number of institutions in Africa. The institution should pay for it, because it's like a very efficient thing for the institution. I don't recall what the exact offer to Makerere looks like, but we get pretty aggressive in the pricing of what it would cost the institution per student. And there's also the option of the institution, how shall I say, making it just like a textbook resource, making it a required textbook reading resource for you, which then, you get a much discounted rate, much below what if you buy a single license, which, by the way, for the audience, like we're talking $300 for the entire year of the entire medical curriculum and $200 for the entire year of the entire nursing curriculum. So it's starting out affordably in many ways, but obviously for the local setting, I appreciate that it's still a lot of money. We do also some differentiation there, but I really want to encourage you, help us also convince the universities to do this systematically, because if you get it through the university, this can be well below $100. And then they can give assignments and track those and make your life much easier, make the faculty life much easier, help the whole system much more, because the individual student buying it is no doubt, as you kindly attested, of great value, but if you actually bake it into the delivery, it's of so much more value to the entire system, so thank you for the question and your kind words. I don't know if I want to add a lot more in terms of final comments. Just want to encourage us to rethink. Often we take the high-income country models and sort of try to replicate them, whether it's on technician education, nursing education, other things. And I think exciting things are possible. If you look how glaucoma surgery gets done in India, those are not fully trained ophthalmologists. If you look at their outcomes, they're amazing outcomes, right? And so, I want to just encourage you to rethink your system and be the leaders in your systems for the experiments that then prove to meet the needs of your populations in a faster way, both on the education side and on the delivery side, and what's possible there these days with both the systems and solutions available. Ours is just one of them. It's unique in many ways, but also in terms of what an AI can enable and new interventions that are possible, it's pretty mind-blowing. And mental health has been a big topic this morning and came in here a little bit as well. And our title, I think, includes resilience, right? Resilient workforce, right? And on that front, we're interested in working in that field. If you are, we have content on that as well. But I just want to mention one funny, I don't know, but AI we think of like it's going to be smart at the analytical stuff, right? It's going to help us get the diagnosis right and so on, right? There's been one interesting piece on AI in medical forums, where not surprisingly the AI gives more accurate answers than clinicians, but it's actually more empathic. So if we think about, like I'm a parent, I have an idea in my head of what good parenting looks like. My practical behavior isn't like that. Sometimes I'm tired, I'm frustrated, I do things I regret, AI has infinite patience and energy and so on. So even on the mental health side, in terms of, coaching, support, education, for people in need, I think there's a lot of potential that's yet to be tapped, just as an example.
Thank you. Let's go on to Judy, please.
Thank you very much, everybody, for being here and listening to us. I think my parting shot really is to say, often we look at the answer from externally. So, what can someone else, maybe we are here at CUGH thinking, what can CUGH do for us, or what can, from high income, can be done. In the previous session, I think one of the directors of the CUGH board was saying we have a lot of homework to go back and do, meaning that she's looking at what CUGH can do. But I think often I like to just tell people to ask themselves what they themselves can do in whatever sphere they're in. And it's amazing if you really take a moment and see what you yourself can do in whatever area and the challenge that you're facing. You actually find the answer without too much external resources and things like that. So just that on a parting shot, and really to encourage us to begin to work collegially, collaboratively, and begin to break some of those silos that have been there traditionally, historically, that are often causing global health workforce issue to be more exacerbated than it needs to be. So I think for me, those are just thoughts to leave you all with, and thank you so much for coming and listening.
Thank you, Judy.
Right.
Yes, Georgina?
So from my end, I want to invite all those who are interested in the cause of AfriHealth to be part of AfriHealth. And I must say that AfriHealth is not only for Africans, because we also have international members, individuals and institutions who are also part. So if you are experienced, you are less experienced, we have a lot to offer the continent and the globe. And so we want to invite all of you to be part of AfriHealth, join us as members so that we can work together. In addition, we are also looking for partnerships with the Stripe HIV project. When we did the evaluation, one of the recommendations is that it is a very good model, and people want to see it in the other conditions, especially in NCDs. So we'll be very happy to have partners who can work with us for us to develop other models based on the Stripe HIV model in respect to NCDs. So this is my call to all those of you in this room who are ready to work with us. We have the experts and we'll be ready to do that so that a lot of people can also benefit from the other conditions. Thank you.
Thank you, Georgina. We'll go on to Keith, please.
Thank you. First of all, Elsie, thank you very much for allowing me to be here with you. It's been fantastic, and we really are grateful for your leadership and that of the entire AfriHealth team that's here and your relationship with CUGH. We're exceptionally grateful. So a couple of plugs. First for Dr. Nancy Reynolds and her subcommittee and the CUGHcapacitybuilding.org. CUGH Capacity Building, please use it. And then Dr. Oladele, the Toolkit 3.2. Oladele, thank you so much again. You all worked extremely hard. It's a beautiful toolkit, and you just keep on advancing that. So please check it out and use it. The 2.0 was used by many individuals around the world. I also want to plead to all of you that a lot of the discussion and issues we spoke about here, to actually address them, really requires that we engage politically. So not only with our health ministries, but we've got to engage our education ministries where much of this resides, as we know, right? And also the finance ministries, as Stefan mentioned. We've got to give a value proposition to governments that have a lot of competing interests for the money that they handle and the political objectives that they have. So we have a strong argument here, we're all committed, but it's a powerful argument you have to strengthen your countries based on strengthening health human resources and having an implemented national plan for what a country needs. And then also there's some nurse leaders with Susan Strasser here, Professor Strasser. They run ICAP, which is an incredible program. We can learn from each other and learn what's already being done. We don't need to reinvent the wheel. But if you take a look at the incredible work of ICAP, ICAP, it's really an outstanding program. A plug for Professor Yvonne Commodore-Menzer's session tomorrow, right, Yvonne? Be there or be square, right? And then finally, Georgina and I are tag teaming on this because AfriHealth is in Nairobi. So if you can make it in August, please be there. The meeting in Maputo last year was absolutely spectacular, right? Puts us to shame. It was wonderful. It was amazing, engaging, dynamic, and innovative. So if you can make it to Nairobi in August, please do. Thank you.
Thank you, Keith. Let's give a round of applause to our panelists. And another one to ourselves for being engaged and being part of all this. Thank you so much for coming, and we continue to work together to make sure that we have an adaptable and cohesive health workforce. Thank you very much and have a nice evening.
Thank you.